Yes, sir. Yes, sir.
Recording in progress.
Yeah. Good evening, everybody. This is an interesting session. It's not a talk, but a group discussion. I could not even call it controversies. Some of the issues are controversies, but most of the time we would call them problems or clinical issues, not even problems as such, because hernia is a very common operation. And in our normal postgraduate discussion, we talk about diagnosis and, talk about a lot of signs and things which may or may not be used very often clinically. But seldom have I seen people discuss in length, particularly evidence-based discussion on day-to-day problems that all surgeons face regarding groin hernias. Okay, it's a very common thing. So what I've done is put together a series of questions that we all face as surgeons dealing with patients with hernia, and try and give you, an overview of what is normally done in these situations. All right, and of course there is an evidence for everything that I'm saying, and you will see the evidence as much. I would like the postgraduates to talk first, and then my respected senior colleagues to say what they have to say, and then the answer, as is seen in the literature, will come on the screen. It is not that everything that's put on the screen is, the Veda Vakya or the gospel truth. There may be some things that can still be controversial. That'll come up for discussion. So the first question: do all inguinal hernias need surgery? Go on, Praveen. Take it and see what you have.
No, no, sir.
No.
Only yes, sir.
Mhm.
Not
Why,
all the
why,
inguinal
why
has
do,
need
what are the
surgery, sir.
things that you consider when you say give that answer?
Sir,
There should be some riders
Sir.
for the kind of hernias that do not need surgery, if you say so. What are those riders?
yes, sir. Sir, usually the direct inguinal hernias
Mhm,
won't cause any obstruction symptoms.
mhm.
So it will it doesn't it does not lead to obstruction, and it will be
So-
mostly of reducible type. So
would you
it may not necessarily.
So would you say that if you have a
Sure.
person with a direct hernia tomorrow in the clinic, that you would not operate on him
No, sir. Until he is asymptomatic.
until he's symptomatic?
And
All right. Okay,
Yes,
Abdul, what have you to say?
Sir,
Are you there?
according
Yeah,
to
go on.
what it was taught to us, it was all inguinal hernia needs surgery.
Why was that taught to you like that?
Because it can go into complication later.
Yeah.
It's better to operate it first time.
Yeah. All right. Any other views, Rajan?
The whole thing is that the emphasis has changed after a fairly detailed study by the veterans at North America, where they followed up a number of people from age 50 to 85 years who had direct hernias or bulges in the groin. And less than 3% actually became symptomatic, leading to need for surgery. So the dictum today is watchful waiting in these elderly people. And if they develop a symptom or discomfort, not necessarily pain, then you consider a surgical option. But otherwise, they are supposed to be left alone.
All right. So this is one of the evidences there. A large group of people, 41 articles, okay, 2 well-controlled RCTs as well. The interesting thing there is that there is a crossover between watchful waiting and operating to anywhere between 23 and 72% of patients. So if you look at the higher figure, nearly 3/4 of people on whom you are waiting will end up having, as Rajan rightly put it, will have discomfort, will have some some kind of a problem with it and will need surgery. All right. So the point there is that you shouldn't worry too much about strangulation. The incidence of strangulation is extremely low. Okay, 0.5% after 4 years, 0.25% after 2 years. But they will have symptoms. So the consensus is that both treatment options are same: watchful waiting and operate as they develop symptoms. But please note that a lot of people will develop symptoms, and the only reason I personally tell them this, but I tell them I would rather operate on you when you're younger than when you develop comorbidities 10 years later. So if I'm seeing a 70-year-old man with a hernia and I wait, and at 80 he develops a couple of CVAs and perhaps an MI or something 10 years on, and he has pain and discomfort, then he'll be a less suitable candidate for surgery. So you would then have a little problem. And so my recommendation is that, yes, if you want to wait, you can wait, but this is one of the downsides. And so you can take a call and come. That is the answer. So both watchful waiting and operating are correct. Rajan, please.
The other thing to be noted is that all of them can be repaired under local anesthesia.
Yeah.
So you really don't have to worry too much on medical fitness and other things as age catches up.
Right.
So that is the reason why waiting has been opted for.
Ravi?
I think, yeah, the major issue for recommending surgery, especially in Indian setting, was the lack of surgical care, in the distant remote areas, which has now almost been obviated by starting of medical colleges in almost every district, and I think medical facilities are available across the board. So I think watchful expectancy is a good policy, but I also I understand and probably agree that if somebody has come to a clinic with a hernia, unless they have been detected asymptomatically for some other reason, then if they have come to the hospital, they probably have some symptoms on it, and I would recommend surgery, all things being equal.
Chandru?
Hello.
Yeah, Chandru,
Can you hear me?
really? Yeah, please go on.
Yes, sir. Sir, one thing is what I have seen is indirect hernias. Even we have refused for surgery, they have landed up with complications in a very short time. So when compared to direct hernias, so with that respect, with keeping age in mind, direct hernias in an elderly can be waited for some time if asymptomatic. Otherwise, if it's an indirect hernia, irrespective of the age, is I think we need to operate.
All right. So the next thing is the classical teaching. Anything that causes increased abdominal pressure, like straining at stool, straining at urination, will precipitate a hernia or result in increased recurrence rate after a repair of hernia. Okay. So let's look at constipation first. All right. One of the students. I have a few visitors as well. Ankur, and I see some other names, Sukanya. Sukanya, can you take it and introduce yourself, please?
Hello, sir. Good evening, sir.
Good evening.
Myself, Sukanya, sir. I'm from WIMS, sir.
You're from?
I'm from WIMS, Ballari, sir.
Ballari, very nice. Okay.
Yes.
So, what do you think? How important do you think is constipation as a causal factor? One of the causal factors for hernia.
Basically, when patient has constipation, when patient stress is there because of that results in increase in abdominal pressure while constipation. That
So you
might
think
result.
that will precipitate a hernia?
Yes,
Abdul?
sir.
Are you there, Abdul?
He's on call. I don't know whether
Okay.
he's.
Sanya?
Yes, so constipation results in increased intra-abdominal pressure, which can precipitate a hernia.
Okay, anybody with a contrary view?
Sir, currently the thinking is that the hernias develop because of the collagen fiber mismatch or the collagen fiber deficiency. All these so-called precipitating factors maybe just bring the problem to notice. I don't know whether they have any contributory role, and certainly I don't think if you have operated on them, of course you are duty bound to try and correct the possible factors that brought you to notice. For example, to control the COPD, asthma, or urinary, lower urinary tract problems, or even constipation for that matter. Of course, you do take the corrective measures against it, but I don't think they will cause recurrence of the hernia.
So please note that there is no association in this epidemiological study as long ago as 1978. Some of them you will find are old references, some of them are very new references. There's no association found with chronic cough, constipation, physical activity at work, and things like that. People who lift weights and things like that. Okay, for some strange reason which could not be explained, this particular study had higher presence of varicose veins and symptoms of lower urinary tract, prostatic hypertrophy in prevalence of hernia. All right, and the reason prostate, one may say yes, but varicose veins, difficult to say. A more recent study, and this is where what Ravi said becomes very important. Disease-related factors like chronic obstructive pulmonary disease, CHF, renal failure, cirrhosis, and other things did not, smoking, chronic cough, constipation, that lifestyle issues did not have much of an importance. The only thing that was of importance was a family history of hernia. Okay, if a male patient with a family history has 8 times more likely to develop a primary inguinal hernia, which essentially means that there is something going on in their collagen. All right, there is something which has not been identified. So please note that there is no clear evidence that all these things that are classically taught, constipation, COPD, have any role. The prostate may or may not be a different issue, and we look at the data for that. You also have more evidence for this. Family history, significant, 0.01. Constipation, not significant, 0.53. So what is your view about BPH? Would that be different from other, increased intra-abdominal pressure conditions, or would it be the same? Sanya?
Sir, again, I think if the BPH is resulting in any urinary disturbance, will precipitate a hernia.
All right. Would it also result in increased incidence of recurrence?
Yes, recurrence also.
Yeah.
That is why TURP is advised in patients having BPH before going the hernia repair.
Yeah. All right. I'll go to the answer right away. Okay, large numbers, please note, the same study in surgery 2007, prostatic hyperplasia, while it did show some influence, did not have a statistically significant thing. Rajan, your hand is up.
See, I'm going to talk something very personal. I'm running into this age of prostate issues. And I find that straining actually reduces your stream. You have to learn to relax and wait, and it comes. Because when you strain, I find that the urinary stream is not that good. And I checked in the literature, and they say that straining, in fact, is not the case. You'll have to stand and relax at the urinal. Vis-a-vis, if you have a stricture or a block which is beyond the bladder, and you need to contract the bladder to get past that in the urethra, then there is intra-abdominal pressure raise. So we have to make sure what that lower urinary symptoms are. And if they are related to stricture, yes, there is a connect to the hernia development. But if it's related to prostate, it's no longer considered as a factor.
Yeah, very, very nice point there. Now, this is another way of looking at it, a slightly older paper. they found that patients with who came for TUR, for example, had a very high incidence of hernia, much higher than the normal population. Okay, and so while you may or may not agree that it is causal, it may not be causal, but there's a definite association. And that has to be counted when clinicians take their factors into consideration. So please understand, causal or otherwise may not be there, but association definitely there. Association with constipation not there. Association with COPD not there. Association with prostatism, it is there. So you need to factor that in when you do hernia surgery. Ravi, your hand is up.
Sir, if you look at the statistics of the inguinal hernias, it is about 10 to 15%, persistent processes vaginalis, and in premature, that the figure may go up to 20%. So if you then look at all the males at 70 or 80, 70 years of age, you will have 70% of people will have prostatism. So putting the two and two together, it is just a coincidence rather than any association, I would think.
Yeah. Okay, I mean, that's a point taken. As I said, causal is something that we cannot talk about, but definitely association is there. And that brings me to Sania's question on the chat box, which says that should we then ask about the history of constipation and COPD? What do you say, Rajan?
Sorry, I was a little distracted.
RCB, 1 wicket down. No. Sania's question is, when we say that these are not major factors in causation of hernia, when we take a clinical history, should we ask patients about constipation and COPD?
No. You should continue to ask about these things because they affect your post-operative state.
Correct.
Because when they have weaker and painful lower abdominal muscles, these conditions get exacerbated. And what little effort which without the patient's knowledge he was using with his lower abdominal muscles will now come into view and further worsen constipation or lower urinary tract symptoms. So they need to be dealt with, addressed either medically or surgically before you tackle the hernia. That is definite.
It is not with the anxiety of recurrence that you do it, but you need your perioperative care will be impacted by all these factors: COPD, prostatism, constipation. And so you got to address them pre-op as well and give attention to them post-op. Okay, that is the important issue. Another paper, a little more recent than the one I quoted earlier, factors also preoperative complications in hernia recurrence for patients under inguinal hernia repair. It's a VA cooperative hernia study. Recurrent scrotal hernias were predictors for short-term and overall complications, regardless of technique. Please note that. Older age and higher on SF 36 were associated with higher risk of long-term complications. Prostatism and BMI were the significant predictors in the laparoscopic group. It didn't seem to affect much in the open group, but in the laparoscopic group, particularly prostatism and high body mass index were important. So when you are looking either open or laparoscopic, please look at all these factors, not because you're particularly worried about recurrence, but because they do have some effect on the post-op care of the patient. Would you do TUR, prostate and hernia repair together? Nikita. Are you there? Is she on call or something?
No, Nikita is not on call. Abdul is.
Abdul is. Okay. Anybody else? Ankur, introduce yourself. Not there. Akhil Bhatt.
Good evening, sir.
Yeah.
Yes, I would do.
Please introduce yourself. Yeah.
Yeah, I'm Dr. Akhil, but I'm one of the consultants at St. Philomena's Hospital.
Very nice. Okay.
I would do a TUR and open hernia repair, but I wouldn't do it with the laparoscopic hernia repair.
Why do you say that?
Because there is always a risk of a rupture of the prostatic capsule, irrigation fluid leaking into that area, and there is concern about associated mesh infection when that happens. So I would hesitate to do, or I wouldn't do a laparoscopic repair with the TURP, but open repair, yes.
All right. Rajan?
Yes, 100% I agree with Dr. Akhil. Open repair and probably do the repair after the prostate operation is over, so that there won't be any of this prostate operation fluid leak and other things coming to soak up your wound. Also, stay out of the retroperitoneum or extraperitoneal area if you have done something to the prostate for the very reasons Dr. Akhil said.
Ravi?
So I don't think there is any major advantage of doing open over laparoscopic repair. I think the point about doing the prostate first is correct. Do the prostate and then do a laparoscopic or open repair, whichever you are comfortable and whichever the patient's condition will allow you to do so. For example, if the patient has high risk in terms of general anesthesia and you are doing the prostate under spinal, then maybe you will be forced to do an open repair. If the patient's general condition is good and you are doing it under GA, if the patient is suitable candidate, then you can do it as laparoscopy as well. I don't think there is any major issues, because if the leak happens, whether it is open or this one, it is the same, because the fluid will come into the space.
This is an old paper, as you can see, in the open hernia era. And it just showed that you can do open hernia and transfer it through the section together without too much trouble. Okay. And this is a retrospective audit, recent one. Please note, this is the era of laparoscopic surgery, combined transurethral prostatectomy and inguinal hernia repair. Note, numbers are small, I agree, but I'll show you another paper as well. In either of these methods, no increase in complications. So laparoscopy would be as acceptable as an open surgery in a combined procedure. Okay, this is a higher number. Okay, 44 patients, and contrary to what has been said so far, herniorrhaphy was always done first, and I have followed this for the simple reason that if you're doing a laparoscopic repair particularly, and I'm sure it will have some effect on open repair as well, if you need not even have a rupture of the capsule, just the TUR process will lead to some transudation of fluid across, and it will distort the anatomy of the inguinal region. That has been, I have experienced it also, it's also been documented. So generally, I always do a herniorrhaphy first, then leave it to the urologist to do his transurethral section. And in all these cases, whichever way you do, there were no significant differences among all groups regarding post-operative complications. All right. In the light of this, further comments from Rajan, Akhil, and Suresh, and Ravi, and from Chandru as well. Yeah.
Nothing to add, that
Nothing
except that I'll still do my hernia second and not first.
All right. Ravi?
Sir, I think this is a slightly different thing. I would probably prefer to do the hernia first, but if the patient is a patient coming from urology, he would like to do the TURP first. If it is my patient, I probably do the hernia first. And then
another twist there. Yeah. Okay. See, for the postgraduates here, there is nothing like this is the correct method. There's more than one correct method. That is surgery for you. And, you look at evidence, and then if the evidence doesn't give you very clear-cut answers, you do what you prefer to do. Okay. That is completely acceptable. Akhil, you have something to say?
When I do open hernias, I like to allow the TURP to be done first, because the irrigation fluid, I'm worried, will flow over the wound and they make a mess there. So from that point of view, I like to ask them to do the TURP first and then do the open groin hernia.
All right. Chandru?
Yes, sir. One thing is I totally agree with Arvind sir that you do open hernia when you combine QRP. My one question is, if you are planning for a lab, what do you do? Either you do TAPP or TEP?
I do
Because
only, go on.
I have a very bad experience of doing TEP after TURP.
Yeah.
Because I lost the plane, then I have to convert to do TAPP. Because I
Yeah.
do normally TAPP, but for TEP also I do. But that was the two cases I had a lot of problem with doing TEP. Then I have to convert on TAPP. And if at all, if you given a choice, what you do?
I do
TAP?
only taps.
Tap.
I tried TEP sometime long ago, in the late 90s actually, 97, 98 taps, and then I said I'm more comfortable with taps. I do only taps now.
Sir, Niranjan here.
Yellappa.
I have done TEPs along with TURP,
Yeah.
quite a few cases, and I would prefer hernia to be done first, and
Yeah.
then TURP,
Right.
because as sir was saying the planes will be lost.
Yeah. Okay, so postgraduates, you know what the views are. They're obviously very different, but none of them is wrong. So you can then watch everything, and when you are a consultant yourself, you do what you think is comfortable.
Sir,
This gone.
in the exams, I think the safest answer to say is that you can do both procedures simultaneously, that is one after the other, but the preference of which surgery to be done and whether it is laparoscopic or open is open to the surgeon in question. I think that would be a safe answer.
Yes, that would be, but I'll be very honest here. I'm here not to train people for exams. I'm here to train people for life as surgeons. And so this is it's very difficult for me to say what is the correct answer in the exam, but I think you should say everything is a possibility and it is left to the surgeon's choice. Okay, and that is a safe answer. Now, is imaging required in the management of inguinal hernia? You see a patient, you see an obvious hernia, okay? And Vinod, come in and say, do you think imaging is required?
Hello, sir.
Yeah.
I feel it not required.
Not required. If I put it to you that it is required, can you think of some reasons why it would be required?
Maybe for some other intra-abdominal pathologies.
Yeah, isn't it? So then why did you say it was not required?
For the management of hernia.
Yeah, even for the management of hernia, if there is some other pathology, would it not impact your management of hernia? It would, wouldn't it?
Yes.
All right. Any other answer? Contrary answer. Sheetal. Is it required or not? If it is required, why would it be required? What are the things that you look for? And what imaging would you do? That's the next one as well. Sheetal, are you there? No? Dr. Savita? Are you there?
In cases of recurrent hernias,
Who is speaking,
imaging is
please?
required
Please
to,
identify yourself.
determine whether the planes have been preserved or not. And in cases of previously.
Is this Sheetal? Yeah. So can you, go on,
Dr.
Sheetal. Yeah, identify yourself.
Yes, sir.
Where are you from?
I'm Dr. Sheetal speaking. I'm an assistant professor in Rajajeshwari Medical College.
Very nice,
So
doctor.
yes, I do think imaging is required in cases of recurrent hernias in order to know the previous plane of mesh placement and to know whether the planes are preserved or not. And also in cases of suspected other intra-abdominal pathologies in order to diagnose them.
Which investigation?
But for diagnosis of hernia per se, it may not be required.
Right. Which investigation do you think will tell you the plane of the mesh dot?
Plain CT is sufficient, sir.
CT. All right.
Yes.
Okay. Yeah. So the guidelines, 213, the British Hernia Society guidelines, okay? You definitely need it if there is no lump and the patient has some symptoms. And also, even if the patient has symptoms, we would like to know if there is any other cause. And of course, we all know that we looked at the importance of benign prostatic hypertrophy. So one of the, in my view, musts is a post-void residue on an ultrasound to know whether there's a large residue. Ultrasound is a good first line treatment, 87, 88% sensitivity and specificity. Okay, if you're worried about ultrasound not giving you the kind of information because of its observer dependency, then you could consider a CT. MRI has not been studied in depth in hernias, and so no specific statement can be made. And in fact, I looked up even recent ones. The recent guidelines also say that CT and MRI can both be used interchangeably if you want an investigation higher than an ultrasound. Rajan.
Right now, a few things. One is the presence of a groin lump is not the cause of, our groin hernia is not the cause of inguinal pain. A reducible hernia gives discomfort but no pain. When a patient presents with pain and there is an associated lump, do not be taken away. Please investigate by further imaging to see if there is any cause for inguinodynia or inguinal pain, which the hernia is a decoy for. You will kind of miss in a more important sinister condition. And one of the places I have got caught is where I have operated for a direct hernia, and it turned out to be a lymphoma of the iliac glands, which I had not seen because I had not imaged. So there is a chance of you missing a cause of inguinal pain and attributing it to the hernia, which may lead you into trouble. Clinical diagnosis, hernia does not need a imaging. If it is associated with pain and you have some doubt, please do the imaging. Lastly, today, the insurance companies are insisting on an imaging result to show that there was a hernia to justify the operation done. So most people are doing the ultrasound of the area to show that there is a documented hernia for which that operation was done.
The point about
thank you.
Some other cause for pain is well taken. Both laparoscopy, and I've been doing laparoscopy from the mid-90s onwards. I've had 2 cases so far taken up for hernia surgery and external iliac nodes seen at surgery, missed an ultrasound, not even picked up on the pre-op ultrasound, biopsied and known to be lymphomas. 2 cases I've had so far. So that's a point well taken. The guidelines 2020, most of the hernias are diagnosed clinically. If in doubt, ultrasound is the imaging of choice. You don't really go for CT or MRI straight away. CT and MRI are alternatives. As I said, if you think that you have issues with your ultrasoundologist or you're not getting the required information, you suspect something else in addition to what the ultrasound has thrown up, definitely you are justified in taking a CT or an MRI. And this addresses Nishant's question. What is its role in occult hernia? It is accurate in 97% in diagnosing an occult groin hernia. So this leads to a real dilemma when clinically there is no hernia, there is some inguinal pain. Ultrasound, dependable ultrasoundologist says there is a hernia. So I go in and operate on it. Okay. And I tell them there's a very small chance that you do not have a hernia. You cannot, nothing is 100% in medicine. Because you have pain, even though I have not elicited a cough impulse, I'll operate on you on the basis of ultrasound. And the one extra step I take it is perhaps you want to consider a second ultrasound opinion to see if the second person agrees with you or not. If the second person doesn't agree with him, you are in deep trouble along with the patient. But that's a different story. Clement, Rajan, you have your hand up.
The point is that many patients nowadays come to you with the ultrasound report, which says there's a small hernial impulse at the deep ring with a small bulge. a defect of 1.25 centimeters or something. But clinically, you're not able to detect anything when you examine them, even in standing positions. So what do you do? So I say, no, I will wait for you to develop a clinical hernia before operating.
Same here,
provided
unless they have pain.
asymptomatic.
Yeah, I do the same thing
If
unless
they're
they have pain.
symptomatic, if they're asymptomatic, I leave them alone.
Correct. Ravi?
Follow up.
So I think, there a lot of these issues that you highlighted are true. I think if for clinically, if there is no palpable hernia, then you probably get if the patient symptoms warrant it, you get an ultrasound, and the ultrasound for other reasons of detecting other intra-abdominal pathology is also well taken. I think that needs to be, for example, again, I had one, sorry, this is just an anecdote, but one patient who was definitely, the ultrasound had said that there was a large hernia, and we went in with that and we couldn't see any hernia there. And I took a photograph and I showed it to the patient's relative and said, there is no hernia, I'm not going to do the operation. That was not the problem. The problem was later the insurance was denied because there was no hernia, and diagnostic laparoscopy would not be, sort of reimbursed for the patient. So these are problems that can happen. But I think all in all, I think ultrasound is probably sufficient, except in rare situations where symptoms warrant a more, sort of investigation of different ilk.
Chandru?
Sir, unless I'm very sure clinically that there is swelling, if the patient is asymptomatic, I'll not venture to do surgery. If patient has a even hernias, groin pain, then probably I'll give a choice to the patient. So you might improve with the surgery, pain might improve with the surgery. So that's my view.
Niranjan?
Hello.
Yeah.
Sir,
go on,
same thing,
Niranjan.
sir. I agree with
Yeah.
them. I have had a few situations where clinically patient had one-sided hernia, but ultrasound had given bilateral.
Yeah.
Most of the time it will be correct, but in few scenarios there was no hernias where I went and explained that there was no hernia, so I have not done the repair that side.
Yeah. So Nishant has raised an issue, painful but no lump, suspicion of femoral hernia. The same rules apply in my view. Groin, you can do imaging of ultrasound. It may or may not show. If you have a very high suspicion that there may be something, you can get a CT. If there is pain in the groin with none of these investigations showing a hernia, I do not think you can either laparoscope them or explore their groin in an open operation. You must look for an orthopedic or a joint cause for that, and not implicate a hernia. Ravi.
Sir, there are anecdotal experiences like this. There was a patient who's an MBA graduate who was in Stanford, and he went with classical symptoms of inguinal hernia. They didn't do anything, or they investigated him and they didn't find anything. He came here, our ultrasound was normal. So I asked our radiologist, his symptoms are so classical, kindly do an MR. And what had happened was the momentum had formed a fine tube, and it was completely lying in the inguinal canal, and it had blocked the inguinal, hence they were not able to see if there is a hernia or not. And then the MR actually showed that there was a hernia, and we operated and he got better. So
that is the point we made, that you go, if you really suspect it, you get a higher investigation beyond ultrasound. And fair enough, the point well taken. Nishant, your hand is up.
Sir, just an addendum to the point what everyone was talking. The reported as bilateral inguinal hernia. We go in, there is unilateral hernia. We do a unilateral hernia and come out. That's the right thing to do. But for our bad luck, if the patient develops a hernia on the side which we have not operated in 2 years down the line, it will that become a medical legal issue, saying because they had a documented evidence that there was hernia?
Yeah.
And can that what do we do at such a scenario?
Yeah. You have seen us do it. One of the ways I get around it is to tell the patient or the patient's relative before, and also reinforce it during the operation, that look, I do not suspect a hernia on, suppose there's a left hernia and there's nothing on the right and bilateral on the ultrasound. I'll go and see, and if I don't find a hernia on the right side, I would prefer not to do it. There's a small chance that it may occur, as you said, 2 or 3 years later, in which case I can do it. But I do give you a choice of me doing it now. It may be an overkill, but it will avoid an anesthesia for you, another session for you. Okay, and I leave it to the patient. And if he says, you do what you want, I will not operate. If he says, no, no, I don't want to come again, do it now, I'll do it. Ravi,
you will do a hernia that is not there?
Yes, with the ultrasound says there is a hernia. And
Right.
I've gone to do one hernia. If you remember, right, I will not do a hernia if there is no hernia clinically.
Yeah.
And the patient's ultrasound says there is a small hernia and the patient is asymptomatic. I will not do it.
Right.
But this scenario that Nishant is saying is, you have gone in for a established left-sided hernia.
Right.
Ultrasound says there is a hernia on the right side also.
Okay.
You go and see laparoscopically, there is nothing there. What do you do is the question.
So
Go on.
I would certainly not do the right side. I will just do the left side and tell the patient, if you the ultrasound is, it's only sensitive and specific for about 95 to 96%.
Right.
So I would not operate on that side. If you develop one, then we will, I think, if the patient, I don't say the risk is not that much that if, as Rajan sir said, if the risk is there, you can do it under local. So there's not an issue.
All right. Other views, Rajan?
No, I agree. I agree with what Dr. Ravi Shankar said just now. And that's how I do it.
Niranjan?
I think we can document and there shouldn't be any medical legal issues, and we can take a photograph and show it to the attenders also. And I think invariably we would have explained them pre-op that this is the plan. If there is no hernia, we will, as you said, we will give them the option.
No, the point then, see, where we are differing, Niranjan, is that during the pre-op discussion, if the patient says, ultrasound says there is a hernia, doc, you please do it.
Yeah, then we probably will have to do it.
But Ravi and Rajan are saying they will not do it.
No, if the patient insists, there is no question of.
I mean, that is different views, I mean, so that's fine. I mean, this kind of difference of opinion does occur and it is completely acceptable. Ravi.
But as surgeons, don't we need to exercise our discretion of doing what is right for the patient?
Yeah, I mean, this is also right because I may be wrong in assessing even laparoscopically. I cannot say that there is I've seen it happen many times. This is a correct point to say this. When you don't actually see a hole from the inside, but on these situations, when you actually dissect the fat out, you can actually see a defect on the muscle. I've seen that happen. So while I'm not convinced that I should do it, if the patient says, please do it, I will do it. Nishant.
Sir, exactly the same thing happened, sir.
Yeah.
Bilateral hernia, took a consent, went in. Right side, there was a hernia. Left side, purely because that patient was one. I shouldn't be saying that he's a person who sits and checks each and everything on Google. So for the benefit of doubt of what the radiologist said, dissected the peritoneum and sure enough, there was a defect underneath.
Yeah, I've seen it several times.
Yeah, probably because of the insufflation or something, we might not see the defect. Yeah. So I thought, even if there is no hernia, we can always stitch up the peritoneum again. But that what you said is a very valid point, sir.
Yeah. Okay. Hernia repair, laparoscopy are open. I will exclude my dear friend Rajan from this discussion. I'm joking, Rajan. I don't mean it. I'm joking. I very much want you in this discussion. What is the current practice? Let us look at one of our guests whom I cannot recognize. Whom shall we call? Sonia Shetty. Are you there, Sonia? Not our Sonia, our registrar. Sonia Shetty. Not there. Priyanka. Not there. Jitendra. Not there. Shalu. Boy, I thought I would invite our guests and I have not had much luck. All right, let's go back to our trusted Vinod. Go on, Vinod.
Hello, sir.
Yeah.
I'll go for laparoscopy, sir.
You will go for laparoscopy. Why would you go for laparoscopy? What is the question there? What is the current practice? Don't reflect what happens in your institution, Sagar. What do you think is the world average of laparoscopy?
Average is open, sir.
Open. What percentage do you think is open?
Maybe 70 to 80, sir.
Approximately. Oh, okay. Yeah, you must have heard one of us talking. Yeah. Sonia, what do you say? And which one would you prefer? Two things. What is the current practice? Which one would you prefer? Registrar Sonia, or Sonia, Sagar Sonia.
Sanya.
Sanya, sorry, not Sonia. Sanya.
So current practice, I think, is laparoscopic repair.
Okay.
70% is laparoscopic repair, maybe 30% open repair.
Okay. So there are two things in the chat box. Surgeon's choice, do what you are best at doing. All right. Both are very, very valid. Now, I was looking at some interesting data from trainee-led audit, okay, which means that the consultant is training the registrars, for example, or SHOs. Okay, laparoscopy was done in only 33% of cases. So 70-30 is a reasonable figure to quote. In England, you must, UK, NHS, you must understand that there are what are called NICE guidelines, National Institute of Clinical Excellence, which clearly said that unilateral hernias must be done by open surgery. They permitted bilateral hernias only for laparoscopic surgery. Okay, so you find that 97% of bilateral hernia, this is in Scotland, remember that, were by laparoscopy, but a lot of them, unilateral hernias, were done by the open method. Okay, Hernia Society guidelines, again British guidelines, and so you end up seeing a tilt towards open surgery for unilateral hernias. Okay, laparoscopic approach may be beneficial if you think that patient is at risk for chronic pain. What those factors are, you will learn as we go along. Okay, for older patients, or those with comorbidity, point that Rajan made and a point well taken, you would do an open operation under local anesthesia. Okay, incidence of severity of pain is lower after laparoscopic repair. So if you want to justify laparoscopic repair, there's only one factor which is supported by strong evidence, and that is a lower incidence of chronic groin pain, defined as pain lasting more than 3 months after your hernia repair. Okay, Akhil, your comments.
Yes, sir. I agree with this. Unilateral, laparoscopic or open, bilateral, reducible, or I tend to offer laparoscopic. If not suitable for general anesthesia, then bilateral open.
Chandru?
Sir, unilateral prefer to do a open surgery. Bilateral always better lap. And one more thing is I explain both pros and cons of open and lap to the patient.
Yeah.
So I tell them sometimes patients come with a choice telling them that we want lap, and sometimes people come with a choice that they want an open surgery.
Yeah.
Even that also to be taken into consideration.
So it is a combination of patient's preference and surgeon preference. Rajan makes the important correct point that recurrence is probably the same in both methods, okay, both open and laparoscopic. Okay, this is a more recent paper, 21 systematic reviews. It's a very large database. Open repair is the most popular. Laparoscopic repair is becoming increasingly popular because of its lower chronic pain. There are lower incidence of chronic pain, but there's no evidence of differences in recurrence rates between open and laparoscopic procedures. What we said earlier has been borne out by this large systematic review as well. Okay, but what is interesting is exactly what all of us said. Tailored approach is followed by a large majority of patients. 80% or 82% of patients have a tailored approach, which means that several things have to be taken into consideration. Unilaterality, whether it's a man or a woman, some of women, in women, laparoscopy is preferred, whether it's bilateral, whether it's a large inguinoscrotal hernia or not. Has there been any previous pelvic or lower abdominal surgery? in which case you would probably prefer an open operation, and comorbidity, which prevents you from giving general anesthesia. All right. And recurrent cases and emergency surgery. If you want to do laparoscopy or open, most people will probably opt for open surgery. We'll talk a little more about recurrence as we go along. Okay, we are going a little beyond time. Would you want me to do another session, or should we continue and finish it? It may go on to 10:15 or 10:20. What do you want to do, Rajan?
I want to go back to the match.
Please.
That's all.
What about others? Yeah, sure. If you want me to do it later, I can do it on another session.
Yes, sir.
Ravi,
I don't mind, sir. It's
another session?
And I'm sure you can carry on. Don't worry.
No, another session or carry on?
Another session, sir.
All right, good. We'll do it because I didn't factor the match in, but we'll do it. We'll do another session because this is an important topic. And I think all of us must, particularly for the youngsters.
The questions coming up need more discussion. There's more variation.
Yes.
So far, it is almost definite information that we are sharing.
Yeah.
Now we're coming to topics. So let's do it on another day, please.
Sure. Absolutely. So I'll stop here. I'll end the meeting. And
thank you, Dr.
Thank you for joining in. And we'll continue the other questions on another day. Okay. And we'll reschedule it for another day. Okay, thank you very much. Any final comments from Rajan and Ravi before we go?
Very interesting, very nice, stimulating, and very down to earth and practical, because the inguinal hernia is the most common operation that we do. The ultimate final point I'm coming is we are not getting enough open cases to teach open surgical techniques to youngsters. So in teaching hospitals, I still prefer the open operation to be the first set of operations done. And when they pass out, then they can get into the laparoscopic approach.
All right, Ravi.
I think so far it's been very good, very illuminating. And, I think students have to take home all the important points that were made. As you said rightly, it is not just about exams. It is about life, how you manage these patients in life. If you manage it well in life, you will be able to pass the exams easily.
Akhil, your final comments, and then we close.
Yes, sir. The questions you have put are all very practical questions rather than exam-oriented questions. I was just telling my postgraduates this morning that these are all the questions that we face when we treat inguinal hernias, rather than answer questions in an exam.
Okay, thank you very much, and good night, everybody.
Thank you. Good night.
Bye.
Good night.
Right, sir.